Hi, my name is Dr. Armida Moreno. I'm a board certified OBGYN in Texas. So I have a story to share with you about a recent life save, which I thought really brought home why an in-house OBGYN presence is so important. It wasn't long ago that I was called by a nurse on the floor that a community doctor had done a C-section a couple of hours previously, and she wanted to let me know or alert me that there had been a high blood loss and that the doctor was on the way and had started some orders, but she wanted another doctor to come by and just take a look at the patient until he arrived. So I arrived to the bedside and she gave excellent report. She told me this patient had had her first C-section after trying an induction. It was her first baby. She was a young lady, had a large baby. She had lost about 1.5 liters in the recovery room, and the nurse was actually in the process of weighing all these pads to really quantify the loss. And then also let me know what the blood loss had been for the surgery. So putting it all together, it was about 2.3 liters that the patient had already lost. She let me know the doctor was coming in about 20 minutes and what the orders were for several medications to help when the uterus needs to contract better. And they were in the process of administering those medicines. She told me, she was a little bit worried about the patient. She felt the vitals had been okay, but wanted me to review them. I looked at the screen and they looked normal at first, but as I looked at the printout, because they had been repeating, there were some very abnormal ones, very high heart rates, very low blood pressures. As I look at the patient, did a couple things on my exam that told me her perfusion wasn't very good. She had a delayed capillary refill. And I looked at her bleeding and it was more than it should be. It was still active, even during my massage. And as I was talking to the patient, her responsiveness was declining. She was having trouble answering my questions. And then she even got to the point where she's falling asleep while I'm talking to her. And that's unusual because when you're in this kind of a situation where everyone's running around and there's a lot of noise and she's being touched everywhere, a normal person would not be able to just start to decline in consciousness. So at that point, I decided to just do a stat transfer to the operating room, and she needed blood right away based on my brief assessment. I would say the time for the nurse to give me a report and the time for me to look and assess her was probably a minute total for me to know she was in trouble. So I asked to go ahead and transfer her, and I helped the team transfer her back as I'm calling the CRNA, the anesthetist, and then I'm on the phone calling for blood, helping the nurse, because during these situations, there's just so many things happening at one time. And you can see that the nurses are giving meds, they're busy. So when you're needing blood at the bed right away, it's me who's going to make that call. So I called the lab and I told them not even to cross match, just to send universal blood, because a cross match would take more time than we had. So we get her to the operating room and transfer her onto the table. And as she's arriving at the table, the blood's getting there, which is amazing. I mean, any surgeon or any doctor who's used to these hemorrhages, there's nothing more gratifying than to see your blood come right away when you have a patient in that kind of a situation. So anyway, the blood starts to go in, and I examine her in the operating room and see that she's bleeding, and I go ahead and I place a newer technology we're using now called the Jada balloon. I tried with the Bacri, but it kind of slid out. I had experience with that device. And when it slid out on me at first, I thought, well, let me just try this Jada. And I put it in. It worked beautifully. If you know the Jada, it goes in, it gives some suction, and the uterus just contracts down, and it's under suction. You can see live what the blood loss is. And the blood loss went down to drops. So that took care of her hemorrhage. And just as I'm, making the conclusion, okay, this is working, her doctor arrives. So in that brief amount of time that he was appropriately responding, we were able to get her blood, transfer her to the OR, put in an intervention to stop the bleeding. And so now that he sees that her bleeding has stopped, everything looks okay, we transfer her back to the recovery room. Now, the private doctor, he hadn't used this technology before, and So he asked, could you leave some kind of guidance for the nursing staff and for me, what to expect or how to manage the device. And thanks to being a hospitalist who specialized in OB emergencies, I was able to get training in this device, pretty early in my career as soon as it rolled out, and was able to give that kind of guidance. It turns out that half an hour after going back to the recovery room, she'd already received her 2 units of blood, plus in the operating room, we'd started to replace clotting factors. When you're losing that amount, it's prudent to replace those to what they've basically been lost with her hemorrhage so that she can go on to clot as she repairs the insult. But she started to bleed again from atony, and he was still there from the initial procedure. So took her back to the operating room, and we were planning on a hysterectomy, and he opened her belly and was able to just put in another balloon, a Bacri, and do an intrauterine injection with another medication, the hemorrhage, and then we watched her a while, and it really did stop. So we were just trying not to get a hysterectomy for her. And on her second return, she was very stable vital signs wise because her blood product replacement had already started. So in the end, she did great. She was discharged with her baby, having received 2 units of red blood cells and the 2 units of clotting factor, and retained her uterus for a future birth. So in reviewing the case, I submitted this as a life save. And I was thinking about why it made such an impact is it really brought to light why it's so important to have an in-house OBGYN. And in our case, as OBGYN hospitalists, we're specially trained specifically for obstetric emergencies. I was a community physician for years before this, and you might in your private practice have a couple of bad hemorrhages in a year. But when you're a hospitalist covering a large group of physicians servicing that facility, it's routine on any given shift to be called to the bedside on hemorrhages or any obstetric emergency, whether it's your patient, someone you're covering, or not. So in this case, you had a doctor that was appropriately responding, was appropriately giving orders, was going to be arriving in an acceptable time for someone coming off site, yet it wasn't fast enough. She was losing consciousness way before he was going to make it into the hospital. She would have decompensated, and she needed blood like immediately. So to have someone in-house that has that level of training as a physician, an obstetric physician, and could see very quickly what's needed and then coordinate it and apply interventions is very, very valuable, and it was life-saving. If she had had a delay in receiving those services, there's no question the outcome would not have been as good.